हो गया 59 तो
I, Good afternoon. I think we will wait for 2 minutes more for people to join in as people are slowly joining in. So we'll just wait for 2 minutes more and then we'll start the Q&A. Good afternoon and a very warm welcome to NITRD, CTD and NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our DDG ma'am, Dr. Urvashi ma'am, and her team from NIRT, NTI, all the STOs, directors of STBCs, faculty of medical colleges, district TB officers and medical colleges. Introducing the faculty from NITRD, I am Dr. Neeta Singla. I am Nodal Officer DRTB Center at NITRD. On my right is Dr. Rupak Singla. He is consultant in Department of TB and Respiratory Diseases. On my left is Dr. Saroj Meena. She is a senior pulmonologist at NITRD. Now I request our director ma'am, Dr. Manpreet Bhalla, to give her introductory remarks.
Good afternoon, everyone, and welcome to today's NITRD Difficult to Treat TB Clinic, which is held in collaboration with CTD and the National Task Force. So we are joined by DDG TB, Dr. Urvashi, who is always ready with her guidance and support for us. Dr. Ashok Bhardwaj, who is the chair of NTF. And this meeting, as we all know, clinic is an important clinic which is attended by many participants, and the target audience is like, as already told, we have DTOs, we have medical officers, we have faculty from medical colleges and others, students, etc. So it's a platform, it's a very good platform to discuss the challenges faced by in the treatment of TB and the diagnosis and the difficult and complex cases like extrapulmonary TB, CNS TB. And here there is an opportunity for meeting with the experts, and everyone can clear their doubts, and also the treatment is discussed as per the latest guidelines and opinion of the experts in the field. Today's topic is treating the untreatable patient. I like the topic, so it is very suggestive, and I think it will be a good case presentation, which is to be done from Kerala, Kochi, and also the case experts and state experts today are from Kerala. And we have Dr. Rupak Singla, senior consultant expert from NITRD, and Dr. Neeta Singla, the nodal officer of Eco Clinics, and who organizes these sessions very regularly every month without fail. So thank you, and I can go ahead with the deliberations. Thank you.
Yeah, thank you so much, ma'am. Now I welcome our DDG ma'am, Professor Urvashi Singh. Her presence is a great motivation for all of us. We always look forward to her guidance in these clinics. I now request her to give her address.
Good afternoon all the participants, my seniors, my colleagues, and all. So, at the outset, I always like to thank the NITRD as an institute for taking this cause of, difficult to treat TB in pediatric, in MDR, in all difficult to treat TB cases. The initiative and, of course, the support that has been built by the program around this, I think it goes a long way for everybody to learn. So it's a continuing medical education for all of us. So we all of us learn. The the case, it seems, must be something that is not responding or needs further care. So here I would just like to refer to our differentiated TB care efforts, where Dr. Singla sir has been the chair of the Reduction in Mortality Committee. And, there has been a special effort by a lot of experts and a lot of, our senior professors, senior peer who have guided us to develop the differentiated TB care guidelines. And the program would soon be releasing this guideline. The idea behind this just being that we identify the patients who need extra care, possibly admission, possibly some intervention. We need to identify such patients early so we can give them the due care well in time. So just alluding to that at right at the beginning, and possibly we can discuss it further later. So with these few words, I also want to thank all of you who have been contributing to our 100-day intensified TB Mukt Bharat Abhiyan. And I would only urge that with the new strategy that we start this campaign, we want to identify the disease early in the high-risk group, that is the vulnerable population. There has been a lot of effort from all of you. All of you have contributed to this, but the idea was just to, set the strategy in context with the evidence available. So the evidence showed us that the high-risk groups contribute substantially to our TB burden, and they are the group who go on to mortality also early. Hence, the idea was to identify disease early, which will not only enhance notification, but also reduce the transmission by breaking the chains of transmission. When the patient is put on treatment, the patient soon becomes non-infectious, but also to reduce mortality by identifying disease early in a comorbid patient, for example, so that at least TB is not responsible for the worsening of the comorbid condition and so on and so forth. Simultaneously, we asked for all these vulnerable populations to be screened by the recommended tool, which is X-ray. We are investigating other tools if possible for screening. Also, we asked for looking for 10 symptoms instead of the classical 4S, which actually just pick the tip of the iceberg, that is clinical TB. With 10 symptoms and an early screening, we could pick up subclinical asymptomatic TB, which may be more prevalent in the vulnerable population. Hence, the strategy was designed around this, and we hope to carry forward the same strategy. So 100-day, again, I urge and request everybody to put their best so we can identify all TB patients, all those who have subclinical TB but are shedding TB bacteria to, break the chains of transmission. And with this, I request Dr. Neeta, again, kudos to the team here today. They have spent endless hours trying to educate or, offer CME to all our colleagues. So thank you, Dr. Neeta, and we can proceed.
Thank you so much, ma'am. Thank you for your words and of guidance. Thanks a lot. So today's case is from state of Kerala, and it is a case, the topic as it says, treating the untreatable, seems to be a very difficult case. Today is case presenter is Dr. Mohammed Salim. He is a consultant pulmonologist and district TB officer from Kochi. The case expert is Dr. Anita Thilakan. She is associate professor pulmonology, and she is also the nodal officer for Nodal DRTB Center at Thrissur. The state expert is Dr. Anita Kumari. She is a retired professor and head of pulmonology medicine from Government Medical College, Ernakulam, Kerala. National expert is Dr. Sridhar, who is the Vice Chancellor, Chettinad Academy of Research and Education. He is also the member of National Technical Expert Group. And we also have the clinic expert, Dr. Rupak Singla, who is consultant in Department of TB and Chest at NITRD. So over to Dr. Mohammed Salim for presenting the case.
Good afternoon, ma'am. I want to say something.
Yeah, sure.
मैम क्या ये जो आप बता रहे हैं समझा रहे हैं इसे हिंदी में भी कर सकते हैं क्या?
हम कर सकते हैं, पर ये जो क्लिनिक है ये डॉक्टर्स के लिए है। और क्या आप डॉक्टर हैं या
मैं हेल्थ केयर वर्कर हूँ।
अच्छा, ठीक है, बट ये मोस्टली इंग्लिश में ही होता है क्योंकि इसमें बहुत सारी मेडिकल टर्म्स यूज होती है। पर फिर भी हम फिर भी हम कोशिश करेंगे कि आपको
थोड़ा बहुत मैम, और सिर्फ थोड़ा बहुत ज्यादा नहीं।
श्योर।
ओके, थैंक यू।
So over to Dr. Mohammed Salim for his presentation.
Good afternoon, madam. Slides will be shared from the right.
Excuse me, Salim sir. So you can project from your side. You have the updated slides. Thank you. Can you please make him the host so that he can?
Sir, it's not able to share it. So can you please?
Yeah,
I'm not able to.
So we are looking at it. Just give us a minute.
Okay. Yes, thank you, madam. So I'm going to present a case with a dilemma in the management. Basic details of the case is a 27-year-old female. We can call her patient X. It's a non-diabetic and non-HIV patient. She has recurrent episodes of pulmonary TB since 2017 and currently on XDR regimen since July 2023. She has a strong family history of drug-resistant TB for her grandfather, mother, and brother. Family history, grandfather had MDR TB in 2014, which was declared cured, and mother had XDR TB as per all definition in 2017. She opted out for Ayurvedic treatment. Her brother in 2018 had H. monopoly drug-resistant pulmonary TB, which he defaulted. And in 2019, again, he was started on H. monopoly drug-resistant pulmonary TB regimen, which was failed. And in 2021, he had MDR TB, which also failed. In 2023, he had XDR TB and he expired out of it. Regarding the treatment history of the present case, in 2017, she had a drug-sensitive TB with treated with the category 1 regimen for 6 months and it was cured. In 2018, she had again drug-sensitive TB, which was treated with category 2 regimen, which was also cured. In 2020, she had a drug-resistant TB, which was treated with shorter MDR regimen with injectable kanamycin for 9 months, which was also cured. In 2021, she developed again drug-resistant TB and treated with all oral longer regimen for 18 months, which failed. And in February 2023, she had a modified regimen by state DT3 clinic with bedaquiline, delamanid, amikacin, linezolid, moxifloxacin, clofazimine, cycloserine for 4 months, and then regimen was changed based on the TST results from Chennai. New regimen was designed in July 2023 with imipenem cilastatin for 6 months, delamanid moxifloxacin high dose, cycloserine, ethionamide, ethambutol, and pyrazinamide. Of this regimen, 12th month, 14 month, and 15 month culture were positive, and she's continuing on it. Regimen is a failure. The current regimen was designed on the basis of the DST report from NRL Chennai on 23/6/23. As per the result, bedaquiline, linezolid, clofazimine, levofloxacin, rifampicin, and isoniazid were resistant, and delamanid, moxifloxacin, high dose, ethambutol, streptomycin, pyrazinamide, and second-line injectables are sensitive. So she was put on injection ibipenem cilastatin 1 gram each IV for 6 months. That delamanid 100 milligram twice daily for the entire duration of the treatment, and tap moxifloxacin high dose 400 milligram daily, and tap ethionamide 375 milligram, tap cycloserine 250 milligram, tap ethambutol 400 milligram, tap pyrazinamide 750 milligram. So whole genome sequencing result on 23/8/23 as per essentially moxifloxacin and delamanid are sensitive, others are resistant. Some microbiological examination results from 2020. In 25 May 2020, smear was positive and LPA result showed rifampicin resistance detected, CAT-G resistance of INH detected. In August, culture was negative, and in January 2021, culture was negative. Whereas in June 2021, again culture positive with rifampicin resistance and CAT-G resistance detected. In August 2021 to December 2021, the cultures were negative, but in 2022, April, again, rifampicin resistance was detected and CAT-G resistance detected. In October 2022 and December 2022, the cultures were positive with rifampicin resistance and CAT-G resistance detected, and second-line LPA fluoroquinolone resistance also detected. In June 2023, again culture positive with the first-line LPA rifampicin resistance detected, H high dose resistance detected, and second-line LPA resistance to levofloxacin and low-dose moxifloxacin detected. From January 2024 to June 2024, the cultures were negative, consistently negative. In July 2024, again, culture became positive. July, September, and October, cultures were positive with rifampicin resistance detected, CAT-G resistance detected, and fluoroquinolone detected, resistance detected. In January 2025, the culture result is awaiting. In December 2024, it was negative, and the X-ray chest of the patient at August 2023. Again, the left side was almost damaged with volume loss and mediastinal shift to left side. There is a involvement of the right upper zone also. In September 2023, she had an effusion and almost same findings with the previous X-ray. In October 2023, so almost same finding. In August 2024, gross volume loss on the left side with gross mediastinal shift to left side, involvement of the upper zone of the right zone. She had recently admitted at Government Medical College, Kalamasheri with various symptoms, and on January 2nd, the X-ray showed this left side involvement with right upper zone involvement, and almost same with not much having improvement in the late part of the month, 28th January 2025. CT report also shows involvement of the right upper lobe in CT pictures shows the right upper lobe involvement pictures. Present condition, patient is still on ATT with delamanid, moxifloxacin high dose, ethionamide, pyrazinamide, cycloserine, and ethambutol, 19th month. 12th, 14th, and 15th month follow-up cultures are positive, regimen is failure, and symptom persisting, radiological signs persisting, and she had initial weight of 28, which improved to 35 kg, and now it is decreasing to 31 kg. She is breathless, having tachycardia, apprehensive she is having a feeling of impending death. Currently, now she has been admitted in Government Medical College, Kalamasheri, with a history of hemoptysis. In January 2024, weight band was changed from 16 to 29 to 30 to 45 for all drugs except the moxifloxacin, considering the intolerance. Thank you.
Thank you, sir. Ma'am, Dr. Anita Thelikan, ma'am, would you like to add anything to the case?
Good evening, all. Hope I'm audible.
Yes.
There's nothing much to add. Like Sir has already pointed out, she has a family history of MDR-TB and XDR-TB, and her brother expired after diagnosing XDR-TB, and he had persistent bronchopleural fistula on left side. Almost a similar case like Ashley, this patient, and she has TB since 2017. Twice she has taken treatment for DSTB, and from 2020 she is on MDR regime. Initially it was shorter regime with kanamycin added. In May 2021 she had all oral longer regime. And it was declared failure after 18 months as culture was positive, and a modified regime was suggested. It was presented previously in the national DT3 also, and it was suggested to change the drug according to the culture pattern. And so we had added delamanid and amikacin along with bedaquiline, linezolid, cycloserine, moxifloxacin, and clofazimine. But after 4 months, we had a result from Chennai NRTI, and there one result had showed resistance to second-line injectables. And so the regime was changed to imipenem celastin, and then delamanid, moxifloxacin high dose, cycloserine, ethionamide, ethambutol, and pyrazinamide. Initially, she was admitted in Thrissur Medical College, the nodal center, and she was given IV imipenem celastin as IV for 6 months. Initially, patient was reluctant to put on a central line for giving the medications. She carried on with one month of IV peripheral lines, multiple peripheral lines. And then finally we could convince her that this will not go on. And then we put in a PICC line, and then we administered for the rest of the 5 months with imipeniselastin. And then rest of the drugs were continued. While she was in the hospital, she had partial improvement in her radiological profile, and also clinically also she had improved, and there was weight gain also. And in January, after discharge from our hospital, in January she had weight gain, and from district TB center her weight band was changed to the upper weight band, but she could not tolerate high dose moxifloxacin, so she was continued on the initial dose of moxifloxacin. All other drugs were upgraded to her next weight band as she had weight gain. But then again, symptomatically patient started worsening, and so the culture then became positive, and so now we are not in a position to start any drug. That's why we have kept it in the national committee. Now she is resistant to bedaquiline, linezolid, clofazimine, levofloxacin, and rifampicin isoniazid is also resistant. She had an initial WGS report also, where the resistance pattern was confirmed, and she was continued on the current regime. Now her current report shows that we had done LPA, rifampicin, INH, low dose moxi resistance is there, and fluoroquinolone resistance is also detected. So now we delaminate, bedaquiline, and clofazimine is also resistant. So we have to decide whether we have to change the regime or not.
Thank you so much, ma'am, for.
And currently, madam, she is now, day before yesterday, she got admitted to Ernakulam Medical College with hemoptysis. It was not massive, but then mild to moderate amount of hemoptysis is there. Her condition is stable as of now. And patient is very much worried about what next treatment she is going to get. Thank you.
Yeah, thank you so much, ma'am. So now we can take questions on the case, any investigation or anything more that you would like to know. So the house is open for questions.
Ma'am, I have a question. The patient developed pleural effusion left, like it was described in the history 1 month back. Was it tapped during that time?
No, madam. No, madam. She had pleural effusion, but she was not that symptomatic. And patient was concerned because patient's brother also had a similar episode. His final episode was a left-sided pleural effusion, which later on turned to ICD was done, and it was a persistent bronchopleural fistula. So she was, they planned to put in an ICD if it is a empyema, but then patient was skeptical. She was asking whether I will also have the same fate of my brother. And then clinically after 2-3 days, she improved, and there was no tachypnea also. So she was better. So they felt like no intervention would be better than to put in an ICD or aspirate. And the amount of fluid was also very less when she presented to medical college. After second day, the fluid amount was decreased because there is associated underlying destroyed lung also. They did not do a tap. They had consulted the nodal center when patient was admitted.
Thank you.
Anita, that case at that time we had done ultrasound, and the fluid was not too much. I mean,
very little,
the
very little
fibrosis
fluid
and
was
the
there,
fluid,
yes.
everything together, which shows like that on the X-ray. Because the fluid was not much, we also did not insist on aspiration or a.
Yes, sir. We were also afraid about the complications.
Yeah, thank you, Dr. Sanjeev. STDC West Bengal and then Dr. Rishi. STDC West Bengal.
Good afternoon, ma'am and sir. It was indeed a very interesting case. I have two questions. One is that is it possible to get that family history. We know that this patient had a family history, and whether the band patterns, LPA band patterns of the earlier members of this family matches with this present case. So we can say that it is epidemiologically linked to some extent. Whether the LPA band pattern of father, mom, and mother and other family member are matching with this current patient band pattern LPA.
So the grandfather and mothers we do not have. We couldn't get the LPA of the brother. The genetic pattern we couldn't get.
Okay. And ma'am, my second question is that uh, there is a CT scan report shows there is a cavitary lesion. It is my question also that in a cavitary lesion, what happens? The mycobacteria multiplies very slowly. They are usually metabolically very inactive. And we know that the ATD, irrespective of sensitive susceptibility pattern, acts poorly in metabolically inactive bacteria. So, is this maybe one of the causes of failure of these patients which have repeatedly been treated since 2017-18 to 2025? Thank you, ma'am.
Anita madam?
While Madam takes over, I'll initially, I would disagree with that. I think the cavity has actively multiplying bacteria in large numbers. So I think what you're saying is not what is actually there. Cavities are known to have very large number of bacteria, and to address bacteria in cavity, you need drugs which actually kill metabolically active bacteria like isoniazid. And also, I think Singla sir and Anta Kumari madam will agree with me, but that is how it is.
Thank you, sir. Dr. Rishi, sir.
Yeah. Ma'am, my question is regarding the culture, from the culture when DST had been done, was it matching with the WGS report? From the culture when DST was done, was the resistance pattern of the drugs from the culture via DST was matching with the WGS report?
Yes, sir.
Yeah,
yes,
okay.
sir, it was matching.
It was matching, okay. And my second concern is, let in such a case, when patient is resistant to bedaquiline, delaminate, and all these drugs, don't we think of surgical section in this case, madam?
So, this is a case of failure. So, subjecting her to a surgery, that option was also taken. But the surgeon's opinion usually is that we treat with a proper regime, and once the patient is better and culture negative, we take up for a surgical procedure. But this time we have not taken a surgical consultation.
Okay.
You see, Dr. Rishi, in this case, if you look at the X-ray and the CT scan, the left lung is totally destroyed, and even on the right side, you can see the upper lobe is involved, the lower lobe is involved. So in that case, the surgical option is out of question because you need the other lung to be healthy. So this is seen in the X-ray as well as in the CT scan also. So I think in this case, we may not consider offering the surgery in the form of resection surgery of the left lung.
Okay, sir. Thank you.
Thank you. There's a
Can I
question.
come in, sir?
Yes, sir.
I think, yeah, Anita madam is there. She will also add in. So I think there was a comment, the earlier comment, we answered the second one. The earlier comment was on looking at the bands for whether the brother and sister had the same bacteria. Obviously, there is it's all inside a family. So there must be some amount of spread. But then the brother's pattern, if you look at the resistance pattern, by the time the brother had developed XDR as per the new definition, bedaquiline resistance and all that, at that time, this girl did not have bedaquiline resistance. So, even though the original bacteria may be the same, but towards the way the bacteria behaved in both these patients is different. In fact, we don't have to look at LPA bands in this particular patient because I think both the culture isolates are available at NIRT Chennai, and they could even go ahead and do a polygotyping or whatever technology they currently have in any of the projects, and we can exactly find out the strains. The mothers and the grandfathers' cultures we don't have. The brothers and the sisters' cultures are definitely available at NIRT Chennai. So I think those cultures can easily be checked as coming from the same But in any case, I think being in a family, because, in terms of inside the family, we would assume that it is spreading within the family. It doesn't add much to the management per se. So that was the answer I need to give to the West Bengal doctor. I think Anita Kumari madam is there. Madam could probably comment.
Man, you're not audible. You need to unmute yourself.
Good afternoon. What I want to add is that we were talking about the genetic bans, but what is more important is the infection control practices within the home of the patient, which we don't usually look into, because in this particular patient, many members of the family have succumbed to the disease, and brother had XTR TB also. That is one point. And another thing is that this patient had received treatment, inpatient care treatment, for a period of 6 months at Government Medical College, Thrissur, when she was getting imipenem cilastatin. So actually, a patient was admitted in the ward, but that was risky to the other MDR TB patients there who were having just rifampicin and INH resistant. So there was a risk of transmitting this extensive disease to other patients also. So I think this extensive resistance TB, this kind managed in Kerala. And I hope that by the end of this discussion, we'll have a solution to this. We don't have many options left. Only few drugs are sensitive.
Just a small thing about the discussion about this polytyping. You see, in our institute, under a project, we started collecting the samples of the household contacts among the patients who were treated for DRTB. So patients were on treatment and the household contacts, they were followed up. Around 5% of them, around 700 contacts were there, they developed tuberculosis. So whosoever developed tuberculosis, we compared their polytyping with the index case polytyping. And we had some families where one of the parent had and the child also. Then we also had examples where one parent and 2 or 3 children had developed tuberculosis. So one very interesting observation was that the polygon in 85% of cases, this polytyping of the index case and the contact case was matching. But in roughly around 15% of the patients, the index case had different polytyping compared to the contact. Although they were staying in the same house and most of the time they were poor, they were living in in conditions where the overcrowding was there. So in a country like India, where we have the high prevalence, so these people must have got infection from the community. So usually we believe that this must have been contacted in the family itself, but there are a few chances, like in this study, around 15%, that the patient may get infection from outside also. And anyways, Dr. Sanjeev said, even if we have these bands and all, the current management of the case, I believe, will not be affected. That we have to treat the patient what it stands today. Thank you.
Thank you. Thank you. We have Dr. Jaykishan asking a question and then Dr. Ritu. And meanwhile, those who are not looking at the chat, there was a...
Can I respond to this as well with the Singla sir?
Sure, ma'am.
So the global publications have clearly shown that in MDR TB, there is polyclonal TB. That is, more than one genotype may be responsible for disease. We have published in 2020 that even drug-sensitive TB, there can be more than one genotype responsible. So what Singla sir said has been proven by, so I think Ruwandi et al. In Clinical Infectious Disease published in DRTB, and there are more papers. We published in PLOS ONE in 2020. Even drug-sensitive TB, there can be more than one genotypes. Hence, to really go back to explain what was the source of the organism will be tricky. And also, I want to say that the family history does not really indicate genetic predisposition here. So let us not mix the two up. If we want to say there is genetic predisposition, then we need to prove it, by doing a test for the known genes for predisposition and so on. Thank you.
Yeah, thank you, ma'am. So there was one question whether NTM was ruled out, and Dr. Anita has replied that yes, multiple cultures have been done and only MTB grew, no NTM was grown. So over to Dr. Jaykishan for his question.
So again, just one statement, NTM can be there, and unless unless we have ruled out the culture as a mix of MTB and NTM. We should not rule it out completely.
Okay.
Again, this is published that mixed cultures can be present, and to distinguish the two is a tricky bit. So that should be done, because where there's a cavity, non-tubercular mycobacteria can flourish. In fact, post-treatment also, if there's a cavity left behind, the non-tubercular mycobacteria could form a film, a biofilm, and eventually lead to disease by, of course, multiplying. So NTM can be a good possibility, and we must rule out the mixed infection. Thank you.
Thank you, ma'am. And I think you've been emphasizing in every clinic that, we should be looking at NTM also. Dr. Jaikishan, sir? I think we can't connect to him. Yes, Dr. Ritu, you wanted to make a comment?
Ma'am, there's an important point. There's an important question in the chat box that this patient has longer than past also. Multiple time first line ATT. So when we make this regimen in July 2023 for an XDR TB, we given imipenem for 6 months only. So that could have been extended as a security, and which makes sense also because most of the other drugs the patient has received for the past 2 to 3 years. So any comment on that? Did we consideration for the extension of imipenem beyond 6 months, 9 months also in such cases?
Madam, can I answer?
Yes, ma'am.
Actually, patient was not at all willing for a PICC line also, but towards the end of 6 months, patient developed a thrombosis in that line, and she was not willing for another line. So we consulted anesthesia multiple times, and she was also on thrombolytics for a few weeks, and only after that we continued the injection. Imipenem. And so as initially we had decided on 6 months, we continued with the 6 months. We were not able to convince the patient to prolong the treatment. She wanted to get rid of that line as early as possible. She's a very, very difficult patient to begin with.
So see, another thing which I would like to add is, like, it's a very, very expensive drug. Imipenem is very expensive. And in these cases, yes, we usually prefer at least 6 months, and we give it for long as is being just in case patients are responding. But I can see it was started in somewhere in June 23, and even the cultures, subsequent cultures were negative. So the 6th month culture was negative, 7th was negative, 8th, 9th month was negative. So I think that could also have been a reason to stop this drug, which is expensive, and patient is also not willing for it. So that could have been a reason. Also,
so there was clinical improvement also.
There was actually, clinically patient improved, weight gain was there, and so, like sir said, cultures were negative. So I think in such a scenario, there is no logic in giving it for further period. It's a very costly drug, and the state already was struggling to procure it funds.
Hello. Hello. Am I audible?
Yes, sir.
So from the very beginning, I may comment that in case the patient is a contact of this MDR, XDR, so in 2017 and 18, the regimen was given of the drug sensitive regimen. So whether we had gone for this, no doubt the patient can get the infection from the community with the drug sensitive organisms, but it can be a good clinical practice to have a drug resistance pattern for all the drugs. And in this case, only H was done, with the first line LPA was done. What were these about the results of the second line LPA and the other drugs to which the father or the grandfather and the brother was sensitive? Another issue here is that the patient is having this much big and destroyed lung on the left side, also on the right upper zone also. And initially the patient in 2023, the patient was responding, but the culture was showing negativity. But here, because the patient started deteriorating, the doses was lowered. Okay, so possibility of the second infections, possibility of these fungal infections, possibilities of the complications in the terms of the carpomanil, pulmonary hypertensions, and the pulmonary, whether it should have been tapped, whether it is because of the cardiac cause or whether because of this the TB causing the pulmonary. So in these type of the cases, we should say always be one second is we should not be satisfied with the culture and activity for TB only. Once this much extensive lesion is there, there is every chance of the patient getting secondarily infected with pyogenic, with fungus, and even NTM, and whether the cultures for the NTM was sent or not. So, and ultimately the patient is having hemopsis. So whether there's a pulmonary embolism or not, whether there is a bronchitis underlying or not, we have to go for those type of the investigations in order to say have a holistic treatment approach to the patient. Thank you.
Thank you, sir. Dr. Puri has raised his hand.
Madam, can I answer that question?
Sure, sure.
So your first question was the contact was MDR. Actually, her brother was H monopoly during the first and second. The brother was diagnosed as MDR in 2021. Ashley was diagnosed as MDR in 2020. So when she was diagnosed as MDR, her brother was not diagnosed as MDR. And her mother also was diagnosed as MDR when Ashley was diagnosed with MDR simultaneously. So, and the second question, whether the second line LPA was done. Second line LPA of Ashley was done in 2020 and 2021, where the pattern was rifampicin resistance, CAG resistance, but SL LPA was sensitive in both these LPAs.
But this is not shown in this slide.
And
okay.
Yes, it is there in the microbiological examination 25/5/2020. It is there in the subsequent slides, sir.
Okay.
And then regarding cardiology, every time when the patient was admitted in our department, in the nodal center, a cardiology consultation was sent. Every time we had sent a consultation, and there was pulmonary hypertension was ruled out, echo was done. Every time patient was admitted, there was no cardiology involvement, sir.
What about the other infections, fungal or the pyogenic?
Yeah, we used to send blood cultures.
Of the symptoms?
Yeah, we used to send all the routine investigations as we do in a pulmonology
so
patient, and everything else was ruled out, sir. Everything else was ruled out, sir.
Ma'am, I have a query. Did you also send for Aspergillus IgG testing? Because as Dr. Jaikishan sir has pointed out, for fungal, usually people end up sending the samples for just fungal culture or KOH microscopy. But this is a very crucial investigation which is missed out. And it has a very important bearing for diagnosing the patients who can have opportunistic or a secondary fungal infection. And it is very, very indicative with high sensitivity and specificity. Just wanted to make a note.
Fungal specific IG was not sent, madam. We had sent cultures, sputum, fungal stain and cultures. Both were negative. So we did not proceed with the other test.
Madam, your point is well taken, but one of the issues is that, if you want to start any antifungal, then there is a huge interaction with bedaquiline and many of our anti-TB drugs. So I think that is something that we need to take into consideration. I think there is always a suggestion that we should evaluate, when somebody is speaking, can that be muted? Yeah. So there's always a desire from our side to do testing for fungus and all that, including the immunological testing. But then there are two issues there. One is on expense, because the government doesn't provide it free of cost. So clinically, whenever we do for our patients, they have to pay for it. And as soon as we diagnose a patient as TB, we ensure that all the testing, everything is done free of cost. And then we start that's where expenditure comes. And second thing is, if at all we find a fungus, it's going to be difficult for us to manage at that point because we need bedaquiline and many of the drugs desperately in this patient, and most of the antifungals will not allow us to give all those drugs. So I think it's a very tricky situation. Your point is well taken, but I think that is it's a bit tricky.
Yeah. Thank you, sir. Dr. Puri, sir.
Good evening. I just want to add one thing, that when the patient was started on your injectable imipenem, and the patient has responded clinically as well as microbiologically, at that time, whether you have to do the surgery for the patient, consider the surgical opinion. Can we operate this patient? Because these patients who are consistently positive with so much resistance, and surgery has an important part to play. So have any stage during when the patient was culture negative, after starting the imipenem, the surgery options were considered?
Sir, initially we had sent a thoracic surgery consultation, sir.
When
but then patient was had just started responding.
that's why I have raised.
So, but then, as sir told, her she had lesions on the right side also. In 2023, when the new imipenem Celestine was started, patient had bilateral lesions. Left side was completely destroyed, and right side also there were lesions. As per X-ray, it was in the upper lobe and lower lobe. So, considering the diffuse lesions, thoracic surgeon told after completion we may try, but then patient failed the regime after 6 months of that.
Thank you so much. Dr. Archana wants to ask a question. Dr. Archana.
Hello, ma'am. Am I audible?
Yeah,
Good
you're
afternoon. I saw 2 years back, I saw a patient, and she was 55 years old. And she was, when I sent for sputum examination, she was +3. So, but she was a case of drug-sensitive tuberculosis. And so I started her on RHZE regime, but the X-ray showed that it was a kind of extensive tuberculosis, bilateral. So I kept her, I added injection streptomycin. But ma'am, her fever was kept constantly very high on subsequent visits. And when the count was done, every time the count initially was 19, 20,000 like that. And every time the count...
sorry to interrupt you. What is your questions pertaining to this patient?
Yeah, ma'am. That is the problem, that her count was every time increasing 34,000, 36,000. So, her sputum was initially +3, and later on, when it was tested after 3 months, it was +1 only. But she had consistent fever, and the count was very high. So, what kind of...
Sorry to interrupt, Dr. Archana. I just want to know your questions pertaining to this patient. Do you have any?
Acha, this case only. Okay.
Sorry to interrupt you.
Okay, ma'am. No problem.
Yeah, sorry.
Okay, thank
so,
you
Dr. Rishi, you have a question?
Yeah. Madam, in this case, since we all know that such a case is there, that since 8 years, this patient is having any sort of drug resistance. My concern is that in such cases, can we do the therapeutic drug level monitoring so that we can know what is the absorption level of these drugs? And in that case, we can give the IV regimen or the oral regimen.
Sir, can I answer that, sir?
Yeah. The question is about therapeutic drug monitoring. Would you like to do it, or did you do it?
Yes, ma'am. So every time, initially patient was responding to our treatment, and she had weight gain also. And we had changed the regime to her higher weight band based on her weight gain and clinical improvement. So we usually, as per state protocol, we send for therapeutic drug monitoring when the patient does not respond to your treatment. But she was responding, and only later, just before, she was considered as failure when her reports came as culture positive and sputum positive. That time only patient started deteriorating clinically.
I'd like to add one more thing. We consider therapeutic drug level monitoring usually when we have a problem with not tenderous resistance. In spite of the patient being sensitive and patient is not responding, that is when we usually consider therapeutic drug level monitoring. So here the problem is patient is having resistance to multiple drugs, and that is the reason why she's not responding.
Thank you, ma'am. Dr. Puri, you still have a question? I think no. Okay, STDC West Bengal.
Ma'am, my question is,
Sorry.
was the WGS done from solid culture or liquid culture? Because to a microbiologist, it is very important. That's why I'm asking.
It was done at NIRT Chennai, so I think we will not be able to answer that question.
Okay, sir. Because I am asking because, sir, if it is from solid culture, then we might have a multiple colonies. It might happen that the patient
So
is
what is the normal practice at NIRT? How do they do it?
actually the actual protocol is that they should maintain both solid and liquid culture.
So because I think it's a NIRT, we have to assume that they are doing the right protocol. No?
Okay, so in the solid culture, you can see different types of colony morphology by which you can say, okay, the patient is suffering from heterotypic, heteroresistance bacilli. But in the liquid culture, it is very difficult to isolate. And if it WGS done from the solid colony, you might get different result or resistance pattern in the WGS. And second point is that one of the report you have mentioned that smear is positive and culture is negative. That is very controversial report, I think. Patient put on DRTB regimen, smear positive, but culture becomes negative. It is very unusual.
Yeah, thank you, sir. Dr. Sanjeev, I have a question. As a DTO, when we are in the field, what should we be looking for to avoid this situation? What should we be doing? Or if we go back, is there anything that we could do for this patient?
If you retrospectively think, we all went through, I mean, I was just, even recently, I met somebody from the past. So we went through a training of DOT. So when I started my NTP training, RNTCP training 25 years back, so the most important thing in TB was compliance. And compliance was not the responsibility of the patient. It was the responsibility of the health system. So it was all up to us to ensure that, we cannot, that was what I was taught when I joined as a DTO in 25 years back, that you cannot blame the patient for not taking the drugs because that is your responsibility. So I think somewhere along the line, we have lost that DOT and we've gone to family care provider and all. So I think there is a major issue there in terms of what we could have done in terms from the very beginning, at least with this family history. This came, the brother's case came in the newspapers. The state TV officer had a major issue. So, this is Kerala and, the news and everybody is running behind to find cases like this. So we should have ensured that both the brother and sister had got each and every dose under supervision. The drug should have been kept with us. So that system somehow we have lost. So that is one thing. The second thing is, from our side, I think generally with implementing differentiated care, one of the major issues is providing hospital care, particularly when a patient is as resistant as this. Her brother also had extremely drug resistant. So people are reluctant to admit this patient, but both the brother and sister were admitted both in Ernakulam Medical College and Thrissur Medical College. So they got full IP care for, like, this lady was there for 6 months, totally hospitalized. The food and everything was provided to her. So I think system also is needed that, maybe because her husband also could not go to work and they were completely without the income. Husband was a caregiver to the patient. Mother had died, brother had died. So they kept on asking to go home. So the more you keep them, the more. So if you have seen models, like if you see the Nepal model or not, where you have hospices, not even a hospital. So each district near the house of the patient, you have a hospice where you provide good food, all the support. In fact, people even get a good pension there. So when that happens, patients can be given care closer to home where, all these things can be taken care of. So at least special needs for these patients. So DDG madam also was mentioning on differentiated care. So this is an apt patient who should get all the possible special care in that scenario. So including nutrition, including psychosocial support, and all those things could have been done for the patient. And I think other than that, her evaluation and everything was done perfectly by the state team and the district team. Only issue is that in terms of our efforts to ensure compliance, so we have to assume when the patient says that. So the brother's case, at least Anta Kumari madam is our state expert here. She was proactive and she caught the brother with bedaquiline tablets in his pocket. So there, after that, we started worrying about his compliance. So, so the clinician had to dig into his pocket and find out those bedaquiline tablets, which he did not take. So I think there is always an issue in that aspect. So I think that is, Anita madam can add further if you have something.
Anita ma'am, over to you.
Yes, actually, this brother of this patient was admitted in Government Medical College Ernakulam when I was working there. So every time he was saying that he was taking the drugs, but finally one day we found out that it was not true. So ensuring compliance is very important, and I think at least for these patients, we have to ensure that directly observed therapy is simply. And as I said earlier, infection control practices should be ensured because we should have a space for treating these patients.
Thank you, ma'am. And now we'll have opinion of Dr. Singla, who's the expert for today's clinic, as to how we should go ahead with this patient.
First of all, I would like to thank the Kerala team for putting this case in the national clinic. They've already discussed this case in their state level clinic. This is one of the very, very difficult cases which I have encountered so far. She is resistant to most of the drugs, and she has been taken care of a team which is very, very competent at Kerala. And I presume Dr. Sanjeev Nair, a very experienced physician, was also involved in the care. Plus, all the entire team, the STO, case expert, all of them are quite experienced in managing such cases. But still, she went on to this. So I was thinking what to offer to her. So let me just summarize the case first. So this is a 27-year-old female with a family history of contact with DRTB. Brother died, then the other members of the family also. And she herself has taken multiple ATT. In 2017 and 18, she took the first line drugs. 2020, she took 9 months shorter oral regimen and was cured, which is important. And May 21, she received longer oral regimen with high dose moxi for 20 months but failed. In February 23, after discussing in the state level difficulty TB clinic, a modified regimen with bedaquiline, delamanid, amikacin, linezolid, moxifloxacin, clofazimine, cycloserine was started. But after that, probably when the DST came, then they decided to change the regimen. And the regimen was changed with effect from July 23, and on that regimen she is still date. That was injection imipin and cilastatin given for 6 months, and as she was converting by culture, the team must have taken a call to stop it. Plus the other things which we have already discussed. This imipin was given along with delamanid, moxifloxacin high dose, ethoramide, cycloserine, ethambutol, and pyrazinamide. And next, and if you look at the DST pattern, you see in June 23, patient had resistance to bedaquiline, levofloxacin, linezolid, clofazimine, INH, and rifampicin, and was sensitive to delamanid, ethambutol, high dose moxi, pyrazinamide, streptomycin, and second-hand injectables. Then the WGS was done in August 23. I believe it was from a private setup. And the sample which was sent to NIRT is still awaited. That's what I could get from the presentation.
Sir, all investigations are with NIRT, IR. We didn't send anything. I mean,
NIRT, sir. It was sent to NIRT. Report is from NIRT, sir. WGS report in 2023.
Okay, 23/8/23. So it showed resistance to INH, rifampicin, bedaquiline, linezolid, and clofazimine, and was sensitive to moxifloxacin and delamanid. However, the DST of 23rd of July, when patient was already on this medication, including delamanid, it showed resistance to bedaquiline, linezolid, the clofazimine, INH, and delamanid. So it means that Most probably there was an augmentation of resistance to delamanid because patient was on delamanid containing regimen and again was sensitive to moxifloxacin and second line injectables. Next. So you see, if you see as a whole, this patient has received almost all the available anti-TB medications except the newer one that is predominant and PAS, which she has never taken. And in this case, constructing a regimen with 4 to 5 effective drugs based on the current national and international guidelines is not feasible because of the extensive drug resistance and the drugs she has used. So now we have two options. One is that we deem the patient as untreatable and provide only supportive care and accept a fatal outcome. Second option is no, we attempt to design a regimen despite deviating from the standard principles and guidelines which may offer a chance of survival. Next. And if you, I think many of you must be aware of it, that at NITRD we had many patients like this. That time even the drugs were which were available were limited. So we constructed a salvage regimen for our XDR-TB patient. We took the permission of Central TB Division. With the case, it was discussed in the ICMR also. So in a semi-research mode, it was agreed that these patients who had taken almost all the drugs and were resistant to most of the anti-TB drugs, they were treated with non-conventional drug combinations. And fortunately, you see, the median age was 24 years only. If we could not have given any medicine, these patients were 99% we can say with the knowledge at that time that they could have died. But with this so-called salvage regimen, where different combinations were used, they had a successful culture conversion in 84% of patients in 4 months. Many lives could be saved. And this experience was published also. Next. So coming back to the which we used to discuss earlier, the principles of designing a regimen in such cases were overall also. You see the first preference is the drugs which have not been used and the DST showing sensitivity from a reliable lab that they should be chosen first. Second choice should be drugs have not been used and the DST is either awaited or not available. Now the third preference should be for the drugs which have been used but still a reliable lab is showing sensitivity. The fourth preference should be the drugs have been used but the DST is not available or is awaited. Now the drugs has not been used but a reliable lab the DST showing resistance, they should be avoided. And about the drugs which have been used plus DST is also showing resistance, they should not be given. Unnecessarily we are increasing the adverse drug reaction and the cost to the patient as well as to the health system. Next. So considering all these points, what I propose in this case is one is the predominant. You see, while currently we all know internationally it has been approved only as a part of BPAL regimen, but it has high bactericidal effect, high sterilizing activity, and this is one drug given with other drugs could be life-saving in this case. So we need to really deliberate at sensitivity division level also that can be considered predominant in this case along with other drugs. Past, yes, patient has never taken it before and the DST is not available because most of the time it is not done, but patient has never taken PS. Then Vikasine, the patient took kanamycin in 2020 as a part of the shorter 9-month regimen, but was cured. Then Vikasine taken in February 23 only for 4 months. So far we see when we review almost all the laboratory reports they show SLI to be sensitive except in one report of 6/6/23 which showed resistance, but then again follow on 23rd of July 24 report the culture DST also shows SLI are sensitive. So Vikasine can also be considered. Then imipenem cilastatin, you see it was used only for 6 months then stopped in July 23 to say December 23. And during this period and even subsequent 6 months, patient was showing culture negative during this period. And the current DST is not available. So we may presume that even imipenem cilastatin may be sensitive in this case. Then coming to high dose moxi, you see it can be considered although it has been used multiple times. If you see the treatment, you see it has been used multiple times for prolonged period. But all the DST reports, all culture DST reports which I was reviewing, including the WGS report, it says that high dose moxi is sensitive. And in this case, we are cornered. We do not have much drugs in hand. So we are trying to give whatever is possible and we are trying to give what the best from our side, because we can't give just one or two drugs. So we have to choose from the other drugs which are available to us. Similarly, for pyrazinamide, it can be considered, although patient is already on this since July 23, and in such scenarios, we believe that patient might have developed drug resistance, but we do not have current DST for it. So what we can do, we can start using it, and then once the culture DST comes, we can always review whether to continue pyrazinamide or not. Next. And of course, as already discussed also, we need to check the compliance previously also, and we must admit now also, suppose we decide to treat her with these drugs, we must admit the patient and then give all these drugs under direct supervision. And I must appreciate Dr. Sanjeev that he raised this issue of directly observed treatment. We belong to that era when this was very strictly ensured. Unfortunately, in the subsequent years, we find that there has been some dilution, and I must thank Dr. Urvashi, madam, that even for the BPRM regimen, she made it right in the guidelines that it would be a physical supervision of more than at least 85% of the dosages. I think gradually we are learning back to go back that the nothing compared to the directly observed treatment with anti-TB drugs, because we cannot expect a patient to take the drugs after say 2 weeks or 1 month once patient is all right. We as doctors have never taken 1 week of antibiotics. I am sure about this. Most of us will stop taking it because we feel better. So expecting a patient who has become better, say in a 1 month or 2 months, to take it for 6 months or 12 months or 18 months is asking for too much. So I think directly observed treatment has to be considered again by the program. We must screen the patient for any immunodeficiency states, that why a patient is not responding. Then, of course, as discussed, the TDM, but you see the challenge will be here will require therapeutic drug monitoring for the second line drugs. So that we have to explore that how to arrange the TDM to second line drugs. Of course, the patient is malnourished. The nutrition support will be very, very important for this. Besides the points which I've already mentioned, the drugs and the compliance and other things, that also has to be seriously taken care of. And another thing is the respiratory support. We should evaluate the patient from physiological point of view. We must do the arterial blood gas analysis. In case patient is hypoxemic, patient will require oxygen support. In case patient is acidotic and retaining CO2, then even non-invasive ventilation, etc., it may also be required. And besides these things, you see, very important will be once we choose a regimen, suppose whatever we are proposing and discussing that is taken up, we need a very, very strict follow-up response to prevent augmentation of further resistance. And so regular culture and sensitivity, I'll say maybe every 2 weeks should be performed at least in the beginning. So how will it help is this will allow the timely modification of the regimen if necessary, and particularly to monitor the emerging resistance to the drugs tested like predominant in case we are using that. So we have to do the repeated culture and sensitivity so that we can document the augmentation of resistance and can take a call at the right time. So that's what I have to submit. Now it's up to the Central TV division and the audience who are attending this clinic to take a call in this case. Thank you very much.
Yeah. Thank you, Dr. Singla. So, any comments or questions?
Excellently explained by sir.
How's the patient faring now? What is the X-ray picture and how's the general condition?
Ma'am, patient has currently got hemoptysis, which was not there for the past 6 months. While on treatment, initially she had hemoptysis for just one episode, for which she was admitted at the nodal DRTB center, and we observed her for 1 week, and she did not have recurrence, and then she was discharged. Now she is again admitted with hemoptysis, which is not severe, but she had mild to moderate amount of hemoptysis, which is subsiding. Patient is better now. But problem is, madam, she has got pleural effusion, and my doubt is whether if she increases her pleural effusion increases, and in case we end up deciding on an ICD, we are not sure whether the patient will be out of the ICD, because the same history happened to patient's brother. He had massive pleural effusion. Intercostal tube drainage was done, but then patient developed a bronchopleural fistula because that lung was destroyed completely, and we could not remove the ICD, and we could not go for a surgical option also. He had repeated infections. So, Madam and Sir, I would like to get a clarification on that also, how to go about.
Is she losing weight? Initially, she gained weight, but as I understand, she again started losing some weight.
Yes, sir. Yes, sir. Recently, she has again started losing weight. But actually, her performance status had increased. She was able to, when she was provided nutritional support, initially after discharging from here, the nutritional support, she was supplied food, cooked food as such to her home. But some 3 to 4 months back, she told she is better. She is able to do her daily household activity. So she told, I can cook myself, and so you can provide me with supplies, which she will do it on her own. So from her that aspect, clinically she is better. Performance status has increased. Now because of this pleural effusion last month, patient has deteriorated a bit.
Regarding this effusion, has it been tapped recently to see whether it is empyema or it is a pleural effusion?
No, sir. It was only a very little amount when ultrasound was done, so we did not prick.
So, in case it is very little amount, then why are we considering the ICD?
Sir, now because the patient is resistant, and if there is increase in effusion,
I believe.
I am just anticipating, sir.
Yeah, no. In this case, you see, even our experience has been not been very good in cases who have effusion, which is not empyema.
Yes.
And we put in the tube, there are chances of converting this into empyema. So in case it is minimal, we just need to follow it up and then see whereby now we have ultrasound CT with us, which can tell us whether it is increasing or not. But I think consideration for ICD should be postponed for the time being, because the fluid is less, and it must have been thickening also, I can presume.
Yes.
So in that case, we may not bother much about the effusion part. Main thing is how to manage her, what are, as we discussed about the drugs and the other additional points, that should be our focus of discussion.
Any questions or comments?
Yeah, Dr. Neeta, I would just like to say, Dr. Singla has Dr. Neeta.
Yeah, Dr. Manpreet, please.
Yeah, Dr. Singla has summarized everything very nicely, and I think as per the suggested regimen, the only thing I would like to say is already Dr. Sanjeev has also said, but that along with the compliance, the counseling, psychosocial support, I think if the proper counseling is given to the patient, because it's a long treatment. And I think differentiated TB care, all this nutrition and as well as compliance and psychosocial support, if that is done, maybe the patient can improve. Thank you.
Thank you.
I have a clarification. Patient is being suggested to give high dose INH, high dose moxifloxacin. So should we give it parenterally, because earlier she was not tolerating moxifloxacin high dose?
Yeah, see, regarding giving in these cases where we are not very much sure about the absorption and they are malnourished, so in these cases, if given a choice, we should give injectable medicines so that at least we ensure that it's going to the blood directly. Because otherwise, for these drugs, the TDM is not possible, and then we are just believing that it is being absorbed. But in such scenarios where they have not responded to treatment earlier, they are malnourished. So in case injectable is available, affordable, and we can give it, I think that should be preferred.
Dr. Singla, someone has asked, Dr. Sameer Singhal, tell us.
I would like to know from the state or the physicians. I hope the imipenem is being given by the physicians or by the program, and the patient is not being tasked to procure it.
No, madam. It was procured by the state and administered. Yeah. We ensured adequate entire stock.
So we support the state with the money for procurement of such expensive medicines, and also we have, going forward, we've asked for requirement from the states to to share with us, so we can suggest either they regarding the way forward. So it is important to us that the patient is not spending from his own pocket while the government spends so much to support them. So that bit kindly take care. Even in the future, any drug which is not made available from the center can be discussed with us. Either we'll supply it or we'll support the state with the funds to procure it. Kindly ensure the patient doesn't buy.
Thank you, ma'am. Everything is taken care of by the state only. Patient
By
is not.
By the TB program, the state is
Yes, ma'am.
part of
Yes,
us.
DB program,
Yeah.
and even the PIC line, we procured the PIC line and inserted it.
Right.
We did not allow the patient to buy.
Thank you.
And regarding one previous query, our microbiologist has confirmed that the liquid culture MGIT was sent to NIRT for doing WGS, sir.
Okay, so I think that was the question asked by STDC West Bengal.
Yes.
Yeah. So there's one question in the chat box is what is the importance of therapeutic drug monitoring? If you can tell us in very short.
I think once Dr. Urushi, Dr. Manpreet are there, and they have had, Dr. Urushi has had multiple publications on this. I'll request her to brief on this.
So we have seen, well, like you said quickly, so I think we're running out of time. You see, what we have seen and we are actually seeing is absorption of drugs in patients could vary. So though we are giving weight-based treatment, there are times that the drug absorption is not adequate because, as you may understand, the molecules sometimes need a carrier molecule. Certain drugs will bind to lipid, certain would bind to protein, and so on and so forth. Hence, of course, also the variation in levels of drugs in different compartments. For example, CSF. The drug levels could vary based on the carrier molecule being adequately, and plus, of course, crossing the blood-brain barrier if we're talking of CSF. So the TDM can help in a case of a failing patient. But then we acknowledge that the facilities across the country are not so many. So one option is that, we have at least 5 to 6 good program labs who can support the therapeutic drug monitoring. For example, NIRT has, AIMS has, NITRD has. The sample can be sent to our labs for helping the patient. We've also observed that, helping increasing the dose can help these patients recover better. Also, the provision of nutrition support can also help in absorption. So, low BMI patients, this is how we introduce the, energy dense nutrition support, or even if the patient is consuming the normal cooked food well and is taking care of the caloric requirement, also the protein requirement, then that will help absorption of drugs. So, with all this, I think we'll be able to help the patient.
Actually, therapeutic drug monitoring is based on two principles. One is PK and PD of the drug. So we can say whether this drug is properly taken, if it is adequately taken, whether the metabolism of the drug maintains the target level, serum level of the that is indicated by this PK and PD. So we can think about particular some situations where I think this TDM can be considered. And it also
Saab, I think I summarize that it can help the patient. And oftentimes we have seen enhancing the dose based on lower drug levels can help the patient. Also, we need to take care of the nutrition.
Yeah. Thank you so much, ma'am. You've very nicely summarized it already. So going back to this case, the most important thing that has come out for me at least is that, when we are starting a patient on treatment, the adherence and the compliance play a big part at the outset before the patient becomes resistant or becomes untreatable. So we should look into these two aspects, look at the follow-up sputum, follow-up cultures, look at the nutritional status, and if required, go ahead with therapeutic drug monitoring. And of course, then has to be referred to a higher center as quickly as possible so that a proper regime can be made and patient can be treated. So with this, we come to the end of the clinic. Generally, the vote of thanks is given by Dr. Ashok Bharadwaj, who is the chairman of National Task Force, but he has a technical hitch, and he has just sent me a message, to thank from him. I should be thanking the Central TB Division for their constant support for this clinic. Ma'am has always been there to support us and to guide us for this clinic. So we really thank entire team of Central TB Division to help us run this clinic. We thank the National Task Force, the medical colleges, and their faculty. Then I would like to thank today's team from Kerala, Dr. Muhammad Salim, Dr. Anita Thelikan, Dr. Anita Kumari, Dr. Sanjeev Nair. Thanks a lot for presenting such a nice case and giving us an opportunity to learn. And at the end, I would like to thank the ECHO team who is, helping us run the clinic, who are the backbone of these clinics. So thank you, ECHO team also. And thank you, Team NITRD, for the support. So thank you, everyone. And with this, we come to end of this clinic. And please give your feedback. Your feedback helps us, to perform and to see like what better can be done in the next clinic. Thank you.
Thank you.
Thank you, everyone.
हेलो शिफा खान। हेलो।
हाँ, निशिता आप बोलो, क्या बोल रहे थे बेटा?
या मुझे अगर नेक्स्ट सेशन में एक केस प्रेजेंट करना हो तो क्या उसकी क्राइटेरिया होगी?
ये जो केसेस है ना, वो नोडल DRTB सेंटर प्रेजेंट करते हैं।
अच्छा, वो नॉर्मल हेल्थ केयर सेंटर वाले नहीं कर सकते, राइट?
नहीं, नॉट इन दिस क्लिनिक। आपके स्टेट के क्लिनिक्स होते हैं। आप कहाँ से हैं?
दिल्ली।
हाँ, दिल्ली में है ना, तो दिल्ली का एक अलग क्लिनिक होता है। उसके लिए आपको STDC न्यू दिल्ली TB सेंटर को कांटेक्ट करना होगा, है ना, और वो उस केस को वर्कअप करके और फिर आप उसको प्रेजेंट कर सकते हैं।
ओके मैम, एक क्वेरी कर सकती हूँ क्या?
हाँ हाँ, बोलो।
अगर पेशेंट फैमिली या पेशेंट अपनी केस हिस्ट्री नहीं बता रहा, इस रिगार्डिंग कैसे पता किया जा सकता कि पेशेंट को पहले भी टीबी है या फिर ये उनको जेनेटिक इशू है?
ऐसे पता करना बहुत मुश्किल होता है। आपको पेशेंट को पूछना होता है, पूछने का तरीका होता है जिससे डॉक्टर्स पता कर सकते हैं कि इन्होंने पहले दवा खाई है क्या। ऐसे काफी क्वेश्चंस ऐसे होते हैं, जैसे हम पूछते हैं कि क्या आपने कोई दवा खाई है जिससे आपकी यूरिन रेड हो गया हो, तो उससे हम रिफैम्पिसिन का पता कर सकते हैं। उनको कोई लंबे टाइम तक इंजेक्शंस लगे हों, घर में किसी और को टीबी हो, तो डॉक्टर्स का अपना तरीका होता है पूछने का, जो कि वो हिस्ट्री पूछ के पता कर सकते हैं कि पेशेंट ने पहले दवा खाई है क्या।
मैम आप तो जानती है ना, आजकल प्राइवेट हॉस्पिटल वाले पैसा कमाते हैं, उनको बहुत चीजों से मतलब तो होता नहीं है। गवर्नमेंट हॉस्पिटल की तरह वो छोटी छोटी चीजों पे ध्यान नहीं देते।
हाँ, नहीं तो उसका देखिए कोई टेस्ट नहीं है इस चीज का। अगर आप वो पूछना चाह रहे हैं कि क्या ऐसा कोई टेस्ट होता है, तो ऐसा कोई टेस्ट नहीं है जिससे हम ये पता कर सकें, बट डॉक्टर्स अपनी स्किल यूज करके जरूर पता कर सकते हैं।
ओके मैम। और मैम इंडियोरेशन में अगर 20 mm दिख रहा है टेस्ट रिपोर्ट में, तो ये कितना मतलब कैसे कह सकते हैं कि टीबी कितना है?
नहीं, इंड्यूरेशन सिर्फ इतना बता सकता है कि इन्फेक्शन है या नहीं, वो डिजीज के बारे में नहीं। तो आप ऐसे करो, कभी भी मुझसे मिलने आ जाना, मैं बैठ के
What's up the
सारी
patient? Has she gone through, has an X-ray, etc. been done? What is her worry? Past TB.
Ma'am, her question is that if patient is hiding the history of TB, is there a way to find out that if she or he is hiding some history?
So current से problem होनी चाहिए, किसी को भी होनी चाहिए, past से किसी को क्या problem होनी चाहिए? You see, we must rule out currently she is healthy, she or he.
No, she is not. She is
not healthy. How do you say that? What is the problem?
उन्हें अभी फिर से टीबी डिटेक्ट हुआ है, तो रिपोर्ट सही नहीं है और
तो
प्रॉब्लम।
आप मैडम से मिल लीजिए,
हम्म
मैडम नीता से मिल लीजिए, उसका इलाज शुरू कराइए मरीज का। सबसे बढ़िया इलाज मिलेगा एनआईटीआरडी में।
वो तो मैक्स में करा रहे
हाँ,
हैं।
तो बाकी चीजें तो सेकेंडरी हैं, इलाज कराइए
जी जी।
और जल्दी से जल्दी इलाज शुरू कराइए, पूरा उसको न्यूट्रिशन सपोर्ट भी मिलेगा।
वो चीजें उनकी मैक्स से हो रही हैं।
तो आप कागज दिखा लीजिएगा डॉक्टर नीता को एक बार।
हम्म। और तो मैम मिलके करना पड़ेगा क्या?
क्या करना पड़ेगा?
मिलके दिखाना पड़ेगा क्या?
आप डॉक्टर नीता को मिल सकेंगे, बहुत दूर नहीं है मैक्स से। कौन से मैक्स में हो रहा है?
साकेत।
हाँ, तो बहुत दूर नहीं है, आप मिल सकेंगे। मिलके
ओके
आप सारी परेशानियां पूछ सकेंगे।
ओके ओके, थैंक यू।
हाँ ठीक है बेटा, आप टीबी हॉस्पिटल में आ जाओ, हम देख लेंगे।
ओके।